Happy to see you there. As senior said, today we are going to learn about the management part two. Last week we have learned about NSAID, paracetamol, weak opioids, and all. So today we are going to learn on opioids. This session will be taken by Dr. Sunilkumar. We all know him, who was our beginning day faculty. Let me introduce once again. He is a palliative care physician, having 19 years of experience in palliative care. Now he is an additional director of Trivandrum Institute of Palliative Science. The Trivandrum Institute of Palliative Science is one of the unit of Pallium India. Sir, welcome back and over to you.
Thank you, Shiva, and good afternoon, everybody. So, you already know about the WHO step ladder 1 and 2. So, NSAIDs, opioids for mild to moderate pain, and adjuvants is already covered. So, we will mainly talk about strong opioids today. Okay, so this is what we are going to talk about today, mainly about strong opioids. What is the action of the opioids? And we will have many doubts regarding the practical application of the theoretical knowledge of opioids. So we will talk about that. Then adverse effects of opioids. And it is also important to know the different prices of opioids, because some patients, not some patients, we don't know what would be the percentage, but there will be some patients who is going to come to you with pain again and again, and you have prescribed many medication each time. But I think one of the factors that will cause unrelieved symptoms would be the compliance with medication. So the patient may not take the prescribed medication because of many problems, and one of that would be the price of that specific medication. And we know that some of the medications are really costly, and patients may not have money to buy it. So that's also very important. So this is the WHO three-step ladder, and all of you know the first step contains non-opioids plus or minus adjuvants. Senior, there is some sound coming from somewhere. Now it's
Is it okay, sir?
yeah.
Okay.
And the second step is for to treat moderate pain. And you can see opioids for mild to moderate pain is an addition there, in addition to step 1. And the third step is for severe pain, and opioids for moderate to severe pain, that is adding to the step 1. And we saw this patient when we talked about introduction to palliative care. So we told that this patient is in severe pain, and he is a person with carcinoma of the larynx, and his main problem is pain, which is very distressing. And you already know the severity pain scale, and in that the pain score is 10 by 10. That means worst imaginable pain. And here describe it as a sharp pain which is not radiating. Okay. And he was unable to sleep for the last 2 weeks because of pain. So if a patient comes to you, how will you manage this patient? Anybody can unmute and speak. I want this session to be interactive. Anybody?
Sir, with morphine?
Okay, can you explain why do you want to give morphine for this patient?
Because morphine is a strong opioid drug, so
Yes.
it will help to reduce pain.
Okay, but according to what criteria you selected morphine? How would we treat pain?
Yeah.
How would we treat pain? Or what is the basis of pain treatment?
To see all the criterias about when there is 4 criteria. So we have to see all those 4 criteria and we have to treat the pain.
Okay, thank you. Anybody else want to try? What is the basis of pain management, or what is the basis of selecting medications? Yeah,
Sir, we have to do the pain assessment first,
yeah,
and
and
then only we have to start medication. First, we have to do the pain assessment.
okay, yeah, that's right. The previous person told that we will select morphine. So I asking you, what was the basis behind selecting morphine for treating the pain of this patient?
WHO ladder.
Yeah, WHO ladder. So why morphine from WHO ladder? There are many other medications like paracetamol, NSAIDs, tramadol. Why don't you select those medications? Why do you want morphine here? Pain should be treated according to what?
Severity.
Yeah, according to severity. So what is the severity of the pain in this patient?
It's 10 by 10.
10 by 10. So that means what type of pain it is? Mild, moderate, or severe?
It's severe.
It's severe. So we can divide the pain into mild, moderate, or severe according to the pain score. 0 to 3, you can call it as mild pain. 4 to 6, it's moderate pain. 7 and beyond, it is severe pain. So this patient has a 10 by 10 pain, which indicates the patient has severe pain. So if the patient has severe pain, which step of WHO analgesic ladder should we use? If the patient has severe pain, which step should be used from the WHO analgesic ladder?
2
or 3.
Three will be used.
There is no doubt. We have to directly go to step 3, not 2, because the patient has severe pain. So WHO first step is used to treat mild pain. Second step is used to treat moderate pain, and third step is used to treat severe pain. So here you have to use opioids from the third step. So what are the opioids that is coming in the third step? Or which are the opioids used for treating moderate to severe pain? What are the opioids? Can you name a few? Which are available?
Morphine,
Yeah,
methadone, methadone,
morphine, methadone. One more.
fentanyl.
Yeah. So these are the only 3 opioids available in India for treating severe pain. Okay. Those are opioids coming in step 3. So this patient, you want to, you have to understand that worldwide, the gold standard for pain management is morphine. So we have to use morphine. So what should be the route through which we have to give morphine in this patient?
Oral route.
Oral route. Okay. Anybody else?
But patient has pneuma of larynx,
Hmm.
so maybe he is not able to swallow the morphine syrup.
Hmm.
So maybe we can choose another route, maybe subcutaneous.
Okay. Um, suppose this patient is able to take morphine orally, then which route would you select?
If patient is able to tolerate oral route, so oral morphine.
Okay.
Syrup.
So I would like to ask another question. Suppose you have pain. How fast you want pain relief?
As soon as possible.
Instantly.
As soon as possible. So do you think this patient also need pain relief as soon as possible?
Yes.
So what would be the route that you are going to do?
IV.
Yes, should be IV, isn't it? I know there are some people who don't have IV morphine, but we should know or understand how to give IV morphine. Okay, so you can see this patient after receiving IV morphine after an approximately an hour, patient is smiling at us. Okay, so what made this possible? It is intravenous morphine titration or intravenous morphine trial. So how would we do an intravenous morphine titration?
Sir, your voice was breaking.
Voice was breaking. So I am talking about intravenous morphine titration.
Senior,
Ma'am, actually we can,
is that voice?
no, ma'am.
So
No.
problem
Clear.
your and Shiva.
Okay.
So we have to give injection morphine 1.5 milligram at 10 minutes interval. Okay. So at every 10 minutes, you will give 1.5 milligram of morphine. So the morphine ampule available for us is 15 milligram, 1.5 in 1 ml. So we will dilute 1 ml of normal saline with, 1 ml of morphine with 9 ml of normal saline. So total 10 ml contains 15 milligram of morphine, and each 1 ml of that will contain 1.5 milligram of morphine. So we will give injection morphine 1.5 milligram at 10 minutes interval. Do you expect any side effect or any immediate side effect by administering injection morphine?
Respiratory depression.
Respiratory depression, not a very common side effect. Anything else? Immediate side effect?
Pupil constriction.
Sorry?
Pupil constriction.
Pupil constriction. Yeah, but more common side effect.
Dryness of mouth.
Yeah, but those are not common side effect, and you will not expect that to occur immediately after 1 dose of injection. What is it?
Nausea.
Yeah, it is nausea and vomiting. Okay, so how do you treat nausea and vomiting? You have to give injection metoclopramide 10 milligram IV before giving the first dose of morphine. Okay, and then you will continue to give injection morphine 1.5 milligram at every 10 minutes interval. And how long will you continue to give this? Either the patient should have satisfactory pain relief or the patient should develop drowsiness. Whichever be the first, you have to stop the trial. Okay. And while doing injection morphine trial, you can make a chart like this so that recording will be easy. You have to monitor pulse rate, blood pressure, respiratory rate, what is the pain score of the patient, is the patient drowsy or not, and what is the dose of injection morphine you have given. So you can see this patient at 10 o'clock, we recorded pulse rate, respiratory rate, blood pressure, and pain score is 10 by 10. Patient is not drowsy. So you will give injection morphine 1.5. And after 10 minutes, the vitals, and you will ask the patient, what is the pain score now? Patient says it's 7. And you are looking at the patient and asking the patient, are you drowsy? No, I am not drowsy. So you will give 1.5 again. So you will continue to give this until the patient has satisfactory pain relief or the patient develops drowsiness. In this patient case, he received only 3 doses of morphine. With that, his pain score, sorry, pain score came down to pain score came down to 1, and patient is not drowsy. So you have to stop the morphine. So what is the total dose of morphine he received? It is 4.5 milligram, isn't it? So you have given 4.5 milligram IV morphine to the patient with a good pain relief, and patient is not drowsy. Is this an inpatient procedure or outpatient procedure? Anybody?
Inpatient.
Okay. Does anybody practice intravenous morphine trial from this group?
Sir, we have tried subcutaneous only.
Okay, okay. Yeah, subcutaneous can also be given, but this would give fast pain relief. So this is how do you do it? Is it making the patient inpatient or as an outpatient procedure?
Inpatient.
Okay, actually, you need not make the patient inpatient. You can do it in a OP basis, and we usually do 2 or 3 trials every day um, as an outpatient procedure. Okay, so you have given 4.5 milligram, and you want to send the patient home. So you have to obviously convert the injectable morphine to oral morphine. So how will you convert the injectable morphine, IV morphine, to oral morphine? Actually, you can give whatever be the dose that has given good pain relief for the patient, that can be converted to the same oral dose. So in this patient, he received 4.5 milligram of IV morphine, but we cannot give 4.5 milligram of oral morphine. So the tablets available are 10 milligram tablets. So you can give half of 10 milligram, that is 5 milligram. That is the nearest dose possible, isn't it? So the first, you can give 5 milligram every 4 hourly. Morphine acts only for 4 hours. So you have to give morphine every 4 hourly. And you can see have morphine should be given first when the patient wakes up. Or you can say it's at 6 a.m. for making it easy, 6 a.m. Then next dose at 10 a.m. Then every 4 hourly, 2 p.m., 6 p.m. and 10 p.m. or at bedtime. So at bedtime, you can see it is double doses given, not the regular 5 milligram tablets. Instead, we are giving 10 milligram. That is the double dose of the regular dose. So this is to avoid patient waking up at 2 a.m. To take morphine. Okay, so double doses are given at bedtime. And in addition, we can also give SOS dose. So the regular dose, what you were giving. So in this patient, 5 milligram is the regular dose you were giving, and SOS dose would be the same as the regular dose. So 5 milligram can be given in addition to the regular dose if the patient has pain. And if injectable morphine is not available, you can give either oral morphine or even subcutaneous morphine. So oral morphine, you can start with 5 milligram of oral morphine in opioid naive patient, that is who has not taken any opioid previously. And if the patient is already on weak opioids like tramadol, you have to start with 10 milligram every 4 hourly. So let's move on to this patient. The first patient whom we saw, he was started on 5 milligram of morphine every 4 hourly and SOS. Okay, and he had a good pain relief, but for the last 4 days, he is taking 4 SOS dose of morphine. Okay, so in addition to regular dose, he is taking 4 SOS dose. What shall we do now? And how frequently would you give SOS dose of oral morphine? So this patient is taking 4 SOS doses. So what should be the minimum time interval between the 2 morphine SOS doses? That's the second question. So can anybody tell me what, do we need to do anything if the patient is taking 4 SOS dose?
Sir,
We can give 8 early.
Sorry, Monica?
increase the dosage of morphine.
Okay. That's very good. Increase the dosage of morphine.
Frequency
And
can be changed.
sorry.
Frequency can be changed to 8 hourly.
Why do you want to reduce the frequency?
Sorry, sir. I wanted to add in between.
So instead of 4 hourly, how frequently would you like to give?
Oh, sorry, sir. I thought it's BD. Sorry.
It's okay. What is the answer for the second question? How frequently would you give SOS dose of oral morphine? Or in other words, what should be the time interval between 2 doses of morphine? Minimum time interval between 2 doses of morphine if the patient has pain. Anybody?
Maybe about half an hour, but if there is pain, then they can take the morphine.
At what time interval?
I'm not completely sure, but I would say half an hour.
Okay, thank you. Let's see. So this patient is taking 4 SOS doses in addition to 4 hourly dose. So what should we do now? So you have to actually increase the dose of morphine. The patient is taking 4 additional doses. That means the dose which you are giving now is not adequate. So you can, if the patient is taking 2 or more than 2 SOS doses, okay, you have to increase the dose of morphine by 30 to 50% every 24 to 36 hours. Okay, so even you can increase the dose of morphine every 24 hours by 50%, 30 to 50%. And so in this patient, he was taking 5 milligram, and you can increase the dose by 50%. That is to 7.5 milligram every 4 hourly. But sometime the patient may find it difficult to break the tablet into 4 pieces. So in such instances, even you may increase it up to 10 milligram every 4 hourly. And how frequently should we give? For that, we have to understand little bit of pharmacology about morphine. So anybody has seen this flower? Are there any participants from UP, MP or Rajasthan?
No, sir.
No.
No.
Okay. So this is the poppy plant, which is legally grown only in 3 states of India, UP, MP and Rajasthan. So that's why I asked participants from these states. Okay. So this is poppy plant, or the plant from which we get morphine, and its scientific name is Papaver somniferum. And you can see the seed like thing, which is known as pod, pod. Okay, and the farmers are making small cuts in this pod, and you can see the sap is coming out. So the farmers will collect this sap, dry it in sunlight, and then they will transport it into government opium and alkaloid factories, from where they will make morphine powder, and they will send it to the pharmaceuticals, and they will make morphine tablet, capsule or injections. And morphine is absorbed from the upper small intestine, and it is water soluble. So you can actually dissolve it in water and can give it to the patient. But the only thing is that it is bitter. So you have to sweeten it with some fruit juice or sugar before giving to the patient. And after absorption, what happens? Uh, Once it goes into the gastrointestinal tract, it is absorbed into the blood vessels of the intestine, and from the blood vessels of intestine, it will go to the portal vein, and from portal vein to the liver, where metabolism of morphine takes place, and the metabolites are liberated into the systemic circulation, and this metabolites will give you pain relief. Okay, so the metabolism of morphine takes place mainly in liver. Okay, and what are the main metabolites after metabolism? There are two components which are formed in big quantities. These are M3G, or in other words it is morphine 3 glucuronide, and M6G, full form is morphine 6 glucuronide. So these are the main components formed after metabolism, and in this M6G is the active component which will give you pain relief. M3G doesn't have much action in our body. So M6G is the component which will give you pain relief. So once you swallow the morphine tablet, what happens? It goes to the GI tract. It has to be slowly absorbed into the blood vessels of the intestine. And from the intestinal blood vessels, it will go into the portal vein and to the liver, where metabolism takes place and metabolites are liberated into the systemic circulation. So this will take some time. Okay. Maybe it will take about half an hour to have pain relief. The pain relief will start by half an hour, but the peak action of morphine will reach only after 1 hour. Okay, so when would you give another tablet of morphine, or what should be the difference between two morphine tablets? What should be the time interval?
Minimum 1 hour.
Yeah, it's minimum 1 hour. Better to wait for 1 hour, because that's the time where the action of morphine peaks. Okay, now because our patient had a severe pain, wasn't it? We started him on 5 milligram, then he needed 4 SOS dose of morphine. So we increased the dose of morphine to 10 milligram every 4 hourly. But the patient says, it is very difficult for me to take it every 4 hourly. As nurses, you are very much experienced this, because most of the patients, when you give tablets, they will tell that, oh sister, there are so many tablets, how am I going to take this? There is a handful. So this patient is also like that. Every 4 hourly it is very difficult for me. Now he says he's willing to take if you give it less frequently. Do we have any option?
We can give slow release morphine.
Okay. So you can tell me the dose and frequency, etc.
It's 12 hourly.
Yeah.
But I can't remember what the conversion, if it is just the daily milligrams they had for them so far, divided by 2.
Okay, thank you, Salami. So we have sustained release morphine, or it is called as controlled release morphine, SR or CR morphine, both are same. And the 4 hourly morphine is called as instantaneous release morphine, or fast acting or immediate release morphine. Okay. So here patient says, give me less frequently. So probably we can convert this into sustained release or controlled release morphine, which will act for 12 hours. So what is the total dose of morphine this patient is taking? Anybody please tell me?
60 milligrams.
Yeah, 60 milligrams. So what would be the dose we need to give in this patient as controlled release or sustained release?
30 milligrams PD.
Yeah, divided by 2, that is 30 milligram PD. But this patient can also have pain in between. So what are you going to do for this? Suppose this patient took 1 morphine tablet at 6 a.m. and the patient says by 2 p.m. patient has severe pain, what would you advise this patient?
Taking the slow release, the 10 milligram morphine.
Okay, it is not slow release. It
Instant
should be
release.
the immediate release. It should be the immediate release. Okay, immediate release or fast acting. That is our 4-hourly, the morphine which acts for 4 hours. That is known as immediate release or fast acting morphine. So in addition to morphine SR 30 milligram BD, you can also give the regular morphine or immediate release morphine 10 milligram SOS. You can see this patient was taking 10 milligram every 4 hourly. So the SOS dose would be 10 milligram. Okay. So what are the preparations of morphine available? There are syrup morphine available at some places, but most places have tablets or capsule, which are either immediate release morphine or controlled release morphine. And injection morphine and the strength would be variable in different states. So our patient who was on 10 milligram of morphine every 4 hourly for the past 6 months. So he had very good pain relief for the past 6 months. But then he was brought to the casualty with excessive drowsiness. And you actually investigated a lot. And you found out that now his serum creatinine is 5 milligrams per deciliter. Would you do anything with morphine dosage? Anybody? The patient has excessive drowsiness. We are unable to wake him up. Anybody want to comment on this? Why this patient has excessive drowsiness?
Shall we have some comments on the chat box,
Yeah.
like reduce dosage,
Hmm.
we decrease dosage, etc.
Okay. Why should we reduce the dosage? And what is the reason for this excessive drowsiness? Are there any response in the chat?
Vishaka says that overdose of morphine.
Okay. So I talked about the absorption and metabolism of morphine. Now we have to understand how morphine is excreted by from the body, morphine and its metabolite. Okay, so morphine and its metabolite are excreted from the body by kidney. Okay, so if the patient has renal failure, what happens? Morphine and its metabolites will not go out from the body. It will be there in the vascular compartment in the blood. So whatever you are giving, the excretion is decreased. So there will be more morphine and its metabolite for action in our body. So that's why the patient became drowsy. Okay. So what should we do? We should actually increase the spacing. That is, instead of 4 hourly, you have to give it every 8 hourly or 12 hourly or even once daily according to the situation. And even reduce the dose from 10 milligram to 5 milligram. Or the another option is you have to select opioids which are renally safe opioids. That is opioids excreted through other routes. So fentanyl and methadone are the two medications which can be safely used in patients with chronic kidney disease. Okay. So we reduce the dose of morphine, okay, to 5 milligram 8 hourly. But after about 2 months, patient was unable to swallow anything, including morphine, because the patient is approaching the end of life and the patient is at home. So what would you do for pain relief for this patient? Anybody?
Transdermal patches.
Yeah, transdermal patches. It's an option, but there are many other problems with transdermal patches. What transdermal patches would you like to give me in action?
In our center, there are fentanyl patches as well as buprenorphine patches.
Okay.
Yeah.
What is the cost, Meenakshi? Price of the transdermal fentanyl patch and the buprenorphine patch?
It will be around 1,000 or more than 1,000, I think. I don't know the exact cost actually.
Okay, thank you. So that's an
Can you-
option.
Syringe driver.
Syringe driver and what now the patient is on tab morphine. So do you want to give injectable morphine? Mahima?
We can start subcutaneous subcutaneous morphine with syringe driver.
Okay, so will your hospital allow the injection morphine to send the patients home?
So, at home it will be difficult.
Yeah, so what will you do? Are there any of you who do home care for the patients?
We have community nurse also.
Okay, so if they face such a situation, what would you do usually?
So
This
community nurse can
is,
start and teach the family member afterwards. We can do that.
So do you give injection morphine?
Now we haven't practiced in community.
Okay.
We have given to inpatient on syringe driver.
Okay. So
Sonia is at rectal route.
yeah. Who told that?
Sonia.
Okay. Thank you, Sonia. So we have to understand what are the routes through which we can give morphine. Okay. So oral morphine, intravenous or subcutaneous morphine. Then you can give morphine parectally, epidurally, and intrathecally also. So these are the routes through which you can administer morphine, and even intramuscularly. But the problem is that after intramuscular injection, there will be pain, and that is the most common side effect of intramuscular injection. So you should not administer morphine intramuscularly. So in this patient, we can give per rectal morphine because the patient is at home, and we have to understand that the per rectal morphine, the efficacy and duration of pain relief, all are same as per oral morphine. So whatever be the dose that you are giving orally, that dose can be given parectally. So 5 milligram 8 hourly, this patient is having good pain relief when you give it per orally. So you can give 5 milligram parectally every 8 hourly. Okay, and you can actually take the fast acting tablet, that is the regular tablet, I told you it is hydrophilic. So add 2 drops of water, make it a paste, and then just rub it over the, do a rectal examination, rub it over the rectal mucosa, rectal mucosa. That's all. You will get good pain relief. So I am moving on to another patient. So we have another patient, Mrs. K, 55-year-old lady with carcinoma of the colon, who has abdominal pain, which is continuous in nature. And she is on 10 milligram of morphine every 4 hourly, and she doesn't require any SOS dose of morphine. Okay, so this patient has a stabilized pain because she doesn't require any SOS dose of morphine. So the doctor has advised them to replace the morphine tablet with 25 microgram of fentanyl transdermal patch. But the patient is coming to you next day and tell you that they actually replaced the fentanyl patch because there were no pain relief even after 5 hours. Okay. So what will you do now for this patient? Anybody?
I think the fentanyl patches take quite a long time to start working, so they should actually get some oral morphine at the beginning until the patch actually starts working.
Okay, thank you, Salome. So these are some problems which usually occurs to the patient because doctors prescribe them patches and will send them home, but there will not be any information or there will not be any communication regarding how to apply, what to do, etc. So it is probably the nurse will speak to the patient and will tell what are the precautions and how to apply, etc. So let's see what happened to this patient. Actually, this has happened to one of our patient or the patient who came to us. So a few points which we have to understand about transdermal fentanyl patches. When you apply fentanyl patch, first of all, it forms a subcutaneous tissue storage. Okay, and for forming this subcutaneous tissue storage, it will take about 8 to 12 hours. That means there will not be good analgesia till 8 to 12 hours after application of fentanyl patch. So till that 8 to 12 hours, you have to give the previous opioid which the patient was taking. So in this case, the patient was taking morphine 10 milligram. So you have to continue morphine 10 milligram till 8 to 12 hours, even after the application of transdermal fentanyl patch. Okay, and usually the effect will last for 3 days. So you have to replace the fentanyl patch every 3 days. And when you apply fentanyl patch, don't shave the area because shaving will cause abrasions in the skin and it will increase the absorption. So you should not shave the area. And it should not be used for patients who has unstable pain. That is a patient who has sometimes the pain is very severe and suddenly it comes down, then suddenly goes up. That means it is an unstabilized pain or unstable pain. So in such patients, you should not use transdermal fentanyl patch. Actually, you have to use immediate release morphine in that situation. Fentanyl is available in 3 forms: injection, transdermal fentanyl, patches, and oral transmucosal fentanyl citrate. Oral transmucosal fentanyl citrate is like a lollipop, and it will give immediate pain relief. So you have to rub it over the oral mucosa so that it will give immediate pain relief. And compared to morphine, fentanyl is more potent. It is about 100 times more potent than morphine. And the conversion ratio is 60. If suppose a patient is taking 60 milligram of oral morphine per day, that is equivalent to 25 microgram of fentanyl patch. So this is another patient, a 70-year-old man with carcinoma of the lung, and is complaining of throbbing pain on right front of chest, which is continuous in nature, and the pain score is 5/10. He is a non-epileptic and is on phenytoin 100 milligram BD. How do you manage his pain? Anybody, please? Anybody? What is the pain score of this patient?
Moderate category.
Sorry?
It is of moderate severe.
Yeah, moderate. So which step of WHO analgesic ladder should you use? Yeah, second. So how will you manage the pain of this patient?
Through morphine.
Is it the second step?
Tramadol.
Tramadol, yeah. It should be tramadol. But what is the problem with the tramadol? Anybody in this particular situation?
Vomiting. There is a side effect of nausea and vomiting.
Yeah, what is it is common for all opioids. Actually, tramadol can reduce the seizure threshold. That means tramadol can sometimes precipitate seizure in patients who are non-epileptic or patients like who has brain metastasis, etc. So in this patient is already a non-epileptic. So it may not be the choice, but if you don't have any other medication, you can give tramadol. But just understand that tramadol can precipitate a seizure in this patient. So what else can be given in this patient? You can start him on low dose morphine. Okay. So maybe 5 milligram or even 2.5 milligram. So we have another patient, Mr. P, who is on tab morphine 50 milligram every 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage the pain of this patient? Pentazocine is available as Fortwin. Okay, and many of you must be familiar with Fortwin. Injection pentazocine is Fortwin. So how do you manage the pain of this patient? Can anybody tell me? Which one would you select? Injection pentazocine or oral morphine? Anybody?
So there are few comments.
Yeah.
Increase seizure, IV.
I think increase seizure was for the previous question, but IV for this question. So which one do you use? Let me explain. So you have to, I know that you have already talked about opioids, and opioids act on opioid receptors. And mainly there are 3 opioid receptors, mu, kappa, and delta. Which is the opioid antidote? This is the opioid antidote. It is naloxone, isn't it? Okay, and based on the action on receptors, opioids can be divided into three: agonist opioid, antagonist opioid, and there is a third group, agonist antagonist. What is agonist opioid? These are opioid which acts on opioid receptors to produce physiological action, that is pain relief. So most of the opioids which we know, morphine, fentanyl, methadone, tramadol, all are agonist. And agonist antagonist means on certain receptors it will act as an agonist, whereas on certain receptors it will act as an antagonist. What is an antagonist opioid? Antagonist means which works opposite to agonist. So I told you naloxone is the opioid antagonist. Suppose I give you naloxone. I am giving one of you naloxone. What would be the effect on your body? Anybody? Anybody? There will not be any effect on your body. It will act only in presence of an opioid. Naloxone will act only in presence of an opioid. So as long as you are not taking any opioid, it is not going to cause anything in your body. Okay, so that is an antagonist. So opioids are divided into three like this, and the main difference between agonist and agonist group of opioid is this. So you can see on the left hand side, it is a graph. On the x-axis, it is the dose of opioid you are giving, and on the y-axis, it is the pain relief. And you can see, in case of agonist, when you increase the dose of opioid, you will get corresponding pain relief. You can see when you give this much, you will get this much pain relief. And when you increase the dose to here, it will give this much pain relief. And when you increase the dose till here, you will get full pain relief. That means this is known as no ceiling effect for analgesia. Okay, there is no ceiling effect for analgesia. So agonist group of drugs have no ceiling effect for analgesia. But look at agonist and agonist. After a certain dose, you can see till this point, as you increase the dose, there will be corresponding pain relief. But even after this point, even if you increase the dose, there will not be corresponding pain relief. The curve is flat. You can see it is flattened. So that means there is ceiling effect for analgesia. So the agonist and agonist group have ceiling effect for analgesia. So until a certain dose, it will give pain relief. But after that, even if you increase the dose, no pain relief. And our pentazocine is an agonist antagonist group of medication. Okay, so because after a certain dose, it will not give pain relief. And in addition, the action you can see, pentazocine, it is an agonist at kappa receptor and a weak antagonist at mu. So when you give it to morphine, what happens? The mu receptors of pentazocine and morphine will compete each other for mu receptor. Okay, and the pentazocine is going to get more mu. So the action on mu receptor for pentazocine is antagonistic, that is opposite to pain relief. Okay, and now the action, you can see pentazocine is also an agonist at the kappa receptor. So there would be some pain, but you can see once morphine is replaced from the mu by the pentazocine, there will be more pain. Okay, so in this patient, you should not give pentazocine. You should give morphine itself. So now I am moving on to adverse effects. Adverse effects can be divided into two. One is side effect and the other one is toxic effects. So what are side effects? Side effects means these are the adverse effects with therapeutic doses. So you are giving morphine or any other opioid for a patient and the patient has good pain relief. Even then the patient can have some adverse effects which are known as side effects. So what are the side effects? Can anybody tell me what are the side effects? Constipation, that's the most
Nausea.
important. Nausea and vomiting, sleepiness and tiredness. These three are the most common side effects. And itching, dry mouth, urinary hesitancy. These are the rare side effects. And constipation occurs in almost all patients. And as long as the patient is on opioid, there will be constipation. So whenever you prescribe an opioid, you have to prescribe a stimulant laxative. Okay, you have to specify the word stimulant laxative. So example is bisacodyl or sodium picosulfate or senna. So whenever you prescribe, please remember or check the prescription. Does that prescription also have a stimulant laxative? It is very important. It need to be continued. In case of nausea and vomiting, it occurs in almost 30% of patients, but only for the first few days, maybe 3 to 5 days. Thereafter, it will be subsiding by itself. And it is due to stimulation of chemoreceptor trigger zone in the brain. Okay, so there is an area called chemoreceptor trigger zone in your brain. And how can we reduce the nausea and vomiting? You can give haloperidol, metoclopramide, or domperidol. So this is the first choice of antiemetic in case of opioid-induced vomiting. We usually use metoclopramide. And the sleepiness and tiredness, this also occurs only for the first few days. And once the body get accustomed to morphine or opioid, that will wean off by itself. So first few days, there may be about 30% of patients can have some drowsiness. Now we'll move on to toxic effects. What are toxic effects? These are the adverse effects when you take more than required doses of opioid. Side effect is adverse effects with therapeutic doses, whereas toxic effect is adverse effect with more than required dose. Okay, and how does it manifest? Delirium. So the patient will be speaking very irrelevantly and consciousness level will vary. Orientation will not be there. So unpleasant dreams. That indicates the patient has delirium. And there will be jerky movements of maybe part of body or whole body. That is known as myoclonus. And the patient will be extremely drowsy. Okay, you will not be able to wake up the patient. So these are the symptoms by which you can understand that patient has toxic effect. And if the patient has toxic effect, you have to skip 1 or 2 doses, wait till the patient becomes alert, and then restart morphine with a reduced dose. So you were talking about opioids causing respiratory depression. Somebody told that whenever when I talked about injection morphine. So how common it is? Sorry. It is not very common. It is very, very rare. And this is these are the a few sentence from a systematic review. So you have to understand that most of the patients takes opioids orally. And what happens when they take orally? The blood level of morphine will rise only slowly. So that ensures that respiratory depression is unusual. And they continues to say that if the patient has respiratory depression, you have to search for another reason. Is there pneumonia? Is there pulmonary embolism or cardiomyopathy? Or is the patient taking a benzodiazepine like diazepam, lorazepam, etc. So just understand that respiratory depression is very unusual. And another thing is this opioid causing addiction. So there are, we can say, two types of addiction. One is actually now it is called as drug dependence, or some people will call it a substance use disorder. So this is the word which everybody understand, addiction or drug dependence. There are two types of drug dependence. One is physical dependence and the other one is psychological dependence. So psychological dependence is known as addiction. Okay. So what is the difference between physical dependence and psychological dependence? Can anybody tell me? I will give you an example. Many of you will be taking coffee in the morning, isn't it? And suppose one day you are not getting coffee, what will happen to you? Anybody
We'll
please?
start having headache. Physical
Yeah.
symptoms will be there.
What are the physical symptoms? Headache.
Yes.
What else? Headache, yawning,
Sleepiness.
sleepiness, irritable. What does that indicate? Do you have addiction?
No, that is physical dependence.
So that is physical dependence. But if you break into the neighbor's house where coffee powder and sugar is kept, then that will amount to psychological dependence. Okay. Usually you will not do that, isn't it? So that's the difference between physical dependence and psychological dependence. So I would like to show you some patient story. This is Mr. X has severe pain and you are starting him on morphine. Please write a prescription. His serum creatinine is normal. Can anybody tell me how will you write a patient who has severe pain and you are starting him on morphine for the first time? Please tell me what all will you write? Anybody?
Tab morphine 5 mg.
Yeah.
4 hourly.
Yeah, that's very good. Anything else?
Tab Dalcolax.
Yes, very good. Tab Dalcolax 5 milligram 2 HS. Because we told that patients who, when we write opioid, there should be stimulant laxative. So Dalcolax should be there. That is bisacodyl. Anything else?
Tab perinom.
Tab metoclopramide, isn't it? Very no. 10 milligram TID because you are expecting nausea for the first few days. So you will raise tab metoclopramide 10 milligram TID into 3 days. But morphine and Dalcolax or bisacodyl, you have to continue. Okay, so the prescription will be like this. Tab morphine 10 milligram, half, that is 5 milligram, isn't it? At 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 1 at 10 p.m. And if they need, they can also take SOS dose. You can write the how many days would you like to give? That is 10 days, and the number of tablets you are providing. Then tab bisacodyl 5 milligram 2 HS, tab metoclopramide 10 milligram TID into 3 days. And you have to also write the review date. So I told you maybe after every 24 to 48 hours, you can review the patient. So review after 2 days. And the doctor has to put signature, name, medical council registration number, and address. So on the top, you should have the patient's name, age, and address. And I would like to end with this. This is very important, as I told you earlier, and somebody told it is very costly. fentanyl patch when I asked. So just understand, when you give morphine 5 milligram 4 hourly, the patient need to spend only ₹3.50 per day. To get the same pain relief, you have to use 300 milligram of tramadol, and that will cost about 24 to 50 rupees per day. Whereas fentanyl, to get the same pain relief, the patient need to spend 250 to 400 rupees per day. And the buprenorphine patch, it will be in the range of 1,000 rupees. But with methadone, it will be ₹4.50. So this is the difference. And there will be many pharmacies stocking buprenorphine patches and transdermal fentanyl patches. But the question is, are our patients able to afford this costly medications? Whenever we write, we have to also think about this. So morphine, methadone, these are cheaper medications. Nobody will promote it. So with this, I think I will end the session. And if you have any doubt, you can ask. Thank you.
Any questions? If you have any questions, please unmute yourself and talk, or you can put in that question in the chat box. Anybody? Sir, they don't have any questions, I think.
So either they have understood all things or they didn't understood anything.
Is there one chat question? Ototoxicity
Okay.
associated.
Ototoxicity is not associated with morphine, but when I talked about nausea and vomiting induced by opioids, I told you that it is mainly by acting on CTZ, but it can also produce nausea and vomiting by acting on the vestibulocochlear nerve. So it is not ototoxicity. It is nausea and vomiting, which is caused by morphine and other opioids. There will not be any hearing defects.
Sir, can we move on to the case presentation?
Yeah.
Okay, Meenakshi. Over to you.
Good afternoon, everyone. This is Meenakshi Dalia here, and I'm a physician assistant under medical oncology, Christian Medical College and Hospital, Ludhiana. And so it was 54-year-old male, diagnosed case of metastatic renal cell carcinoma. Yes. Then it was 54-year-old male, married, resident of Moga, Punjab, with systemic hypertension, diagnosed case of renal cell carcinoma. And he presented to us last time was clinical progression of disease, fever that was on off, right side chest pain which was moderate to severe and radiating in nature, and abdominal distension. So history of illness, he first came to us in 2020 with renal cell carcinoma, nephrectomy was done in November. He was a known case of systemic hypertension, and his disease was metastasized into December 2020. And we started him on a tab pesopenif, and he received tab pesopenif till January 2021. And there was a progression-free survival till 9 months. After that, PET-CT was done and showed disease progression. And we started him on immunotherapy with nivolumab, and he received 10 cycle of immunotherapy. After we did interim this PET scan, and the disease was stable. But after the 10th cycle, his disease progressed, and we add on chemotherapy with immunotherapy. Then we added cabozantinib with nivolumab. And then patient was, we have seen the partial response after that, but after some time, he came to us with the neurological symptoms, and MRI brain was done, which showed the brain metastasis, and WBRT, that is the whole brain RT, was given to him. And because we consider it as a disease progression, then we started him on a tab lenvatinib with tab everolimus. That was the 4th line of therapy for him. And but with lenvatinib and everolimus, he had so many toxicity, because everolimus tend to cause the fever, loose stool and all. So that's why we decreased the dose to 8 mg. And then after that, patient again started showing the symptoms, and it was a clinically progression. Then we put patient on a best supportive care. So on examination, when he last presented to us, his ECOG was 4, that is the performance status. If ECOG is 4, that means the patient is bed bound and patient remains on bed more than 50%. Yes, then pickle was not there. Its left side air entry was decreased, right side air entry was fine, CVS fine, and PA, because he came to us with the ascites. Then there was a distension, abdominal distension was there. There was a hard palpable mass on the left hypochondriac side. CNS was 15/50. GSS was 15/50. And as he was on supportive care, then he had fever, we did culture was negative. He came to us with the chest pain. Then we did the echo. LVEF was 55%, and like he was a terminal ill patient. Then for that, his investigation was within normal limits for us. Then we did the cytic tap, and there was KOH, AFP, everything was, there was nothing there. Only ADA was 16, CBNet was 10, that was negative. And the SAG was exudative. Change slide. Okay, so psychological, change the slide. So the psychological aspects are 54-year-old man, married, sick by religion. He was a strong believer, and his wife was very supportive. He had 2 children. Both the children was based in Canada, and they were unmarried. And he had a financial constraints after taking immunotherapy, because immunotherapy cost him in lakhs. It's a bi-weekly, and in each session, he has to pay 1.5 or 2 lakhs. So after taking the immunotherapy, he faced the financial constraints. Then ECOG was 4, then he was mostly on the bed or on a wheelchair. He was not able to do his daily activities. So I must say that like in India, if you have unmarried children, then that is also a psychological aspect for our parents, that if they died before getting married to their children, and there was a financial constraints and the patient was on bed. So the medication, he was on the following medication, and we on discharge, we put him on a nitrofurantoin 100 mg BD for 5 days, tab Aroref 40 mg OD, tab Amlong 5 mg OD, tab Dulcolex 2 tab HS per oral, and tab paracetamol 650 mg quarter 6 hourly, tab Thyronome 75 mg. He developed this thyroid toxicity after giving the immunotherapy. That is a very common symptom that appear in the patient who receive the immunotherapy. They have the itis kind of symptom. So they can immunotherapy can cause thyroiditis, and can the TSH level can be deranged. Then he was on a tab Calgro and Domstel for and tab morphine SR 10 mg BD, tab Nervide, tab pregabalin 75 mg HS. Because he was more than 50% on bed, then we started on anticoagulant prophylaxis. We started him on injection Clexin 16 mg subcutaneous. So the main concern, his ECOG was 4. He had excruciating chest pain and discomfort related to the pleural thickening and effusion, abdominal distension related to significant ascites, loss of appetite, documented weight loss related to disease condition and poor intake, and toxicity related to the chemotherapy. So yeah, treatment we had already discussed in the slide number 4, but the pain management we have done for this patient. So when it's a this flow chart is from 2020 to 2022. Okay, this is not a one-day chart or something like that. When he came to us, from that time only he then when the disease metastasized to the lung, that from that time he started developing the pain, but the pain was not very severe, but it was a persistent pain. So we started him on a tramadol 15 mg quarter 8 hourly and paracetamol 1 gram quarter 8 hourly, but pain did not subside. Then we increased it to 6 hourly and the paramol was safe. And then we changed it when on discharge to tab tramadol Q6 hourly and tab paramol 1 gram Q8 hourly. Then pain got subsided for this 3 to 4 weeks, and patient got stable on tramadol. But again, after some time, he started having the pain. Then tramadol was not available that time. That 50 mg plain tramadol was not available that time. So we started him on tramadol SR 100 mg 12 hourly with paramol. Okay. Pain was after for some time the pain was stable on SR also. Patient was pain free. He tapered the alternate SR, but after some time, because he has very progressive disease from the starting. The disease he never had response with anything. There was always disease progression on after end of every therapy. So when he again came to us, we started him on a morphine infusion, and when the pain settled on the morphine infusion, then we tapered it on the oral morphine, then which discharged him on an oral morphine. But still there was a pain. She always, like, it was not a very severe, it's not very severe, it was a 7, it's a 10 out of 7 pain. So we switched. He again came to us, got admitted. Then we started him on a fentanyl infusion. Excuse me, wait for a second. Yeah. Then we started fentanyl infusion for him, and after the 12 hours of infusion, we applied the patch. We applied the patch and gave infusion for the 12 hours. And after that, patient pain was okay. Then we discharged the patient. Patient was without pain for 3 to 4 months, even though I can say it was a 6 month, but we are taking it as around 4 months. Patient was painless without any analgesic for 3 to 4 months. But then there was a disease progression. Again, patient came to us with the pain and with other symptoms, the other disease, progressive disease symptoms. Then we kept him on the fentanyl patch, and but again the patient was in that time the fentanyl patch was not starting. They said that we can't give fentanyl patches at home. We can't deliver fentanyl patches like OPD basis. So for buprenorphine patches, we can apply it for the 7-day. That's why we changed the fentanyl patch to buprenorphine patch because of they were not able to come after every 3 days. Okay, because we were able to give only one fentanyl patch at a time. So we changed this fentanyl patch into buprenorphine patch, and again we started paracetamol plus Boveron along with that. Then pain settled on the buprenorphine patch. Then we tapered it to the morphine SR 10 mg quarter 12 hourly and paracetamol. And the patient, this pain was stable because during that time the patient was on a supportive care only. So the pain was starting getting better on morphine SR. Even though he was in the last days of his life, he was taking the morphine SR SOS, and the pain was better, but he died due to the disease progression. So these are the points for the discussion. Yeah, if we could have get a chance to preach, how could we improve the quality of the patient's life and his family, and how to give the psychological support to his family.
Thank you, Meenakshi, for the wonderful presentation. I hope this presentation was clear. If you need any clarification regarding this patient story, please ask us. Otherwise, we can move on to the discussion point. Anybody need any more clarification? Okay, thank you. I think we can move on to the discussion point. The first question, if we could get a chance to keep this patient, how we could improve the quality of life of the patient and his family. Is there anything else to add? We would like to hear from the participant side. Please. Please unmute yourself and talk.
We could improve his sense of accomplishment by saying like he has performed his duty very well, and he has made his both sons independent and competent enough to earn for their livelihood. So that way.
Thank you. Any other points? Sir?
These are the basic questions which I think all of you should answer. Are there any other ways to improve the quality of life of patients and his family? So to improve the quality of life, we should first understand or explore what does the quality of life means to the patient and family. So the quality of life will not be the same for us and to the patient. So the only patient can tell us what is the quality of his life and his family's life. So we should ask the patient, what do you want? If we do, or what are the things which we can do to improve your quality of life? Maybe you were telling that the patient had a pain score of even though he had the pain relief, the pain score was 7/10. So that might be one area which we could have improved very easily. And I don't know what is the psychological status of this patient, whether he knows about the disease and its progression, what was communicated, uh, does he has any doubts about that. And as you told, one of the important point was the unmarried daughters. So was it causing psychological problem to the patient? And uh, actually, whether I would also like to take this discussion to another point, which I think may be beyond our limits, but still I would like to ask Meenakshi that was it needed to give immunotherapy for this patient? Was it, is it justifiable?
According to data, like in this kind of patient, RCC, because RCC's in RCC immunotherapy works because till the 6th cycle and 7th cycle, he has a partial response. He had pleural effusion from the starting only, but still the other lesion and everything and the pain basically when he was till the 7th cycle is when because after every 4th cycle we has done this scans that whether because we don't give because immunotherapy is very costly. If patient if we don't see the response in 2 cycles or 3 cycles, we don't give because giving 2 lakh every bi-weekly it's not a easy. Whether you're a rich, people can't afford to give bi-weekly 2 lakhs rupees. So yeah, so we do this thing. We do scans. If we see that there is no response or then we don't give. But according to the data, according to the researches only, we have gone through this thing because.
Okay, that's okay, Meenakshi. I'm not an expert on this, but which I felt was it necessary? And even at the end of life, there were some investigations, many investigations which were done, and according to that investigation, we couldn't do anything. So, what I wanted to my point is that whenever we do some investigations, with that investigation we should be able to change the management, then only we should do investigation. If we are unable to change any management with an investigation, we shouldn't do anything, we shouldn't do the investigations. Okay. And as Meenakshi is not the deciding person, her unity for somebody will be taking decisions. And what happened to unmarried daughters, Meenakshi?
Get back to Canada. They based in Canada basically. He was having one son and another daughter, and his daughter was nurse, and they both were settled in Canada. So they get back, sir, because 1 week only, 1 week back only got expired, sir.
Did he express any wish?
No, sir, no, never, sir. Because like patient was very cooperative and he was very patient. And yeah, when he never, I have seen very less patient like this because he never ever complained for anything. The only thing he complained about was pain.
Okay.
But yeah, because his kids was not very like they were like 21, 22 years. Yeah. So he never talked about the marriage or something like that. Never.
Okay. 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 So whenever we think of quality of life, think of all the aspects, that is physical, psychological, social, financial, and spiritual aspects. And I think he and his wife were alone. Um, so I think we should. Do you have any social worker with you? Meenakshi?
Thus, we don't have any social workers. We only call the patient and we ask. Day before yesterday only, I talked to his son and I asked about his mother and how she's doing and about his family. Because we only we are working as a physician assistant. We have 4 people here, as a physician assistant. So we work up the patient and we follow up the patient.
Okay.
For everything, yes, sir.
Yeah. Maybe as what Meenakshi did was a very good thing, because even after the death of the patient, she could call the son and ask about the family, how they are coping, which is a part of bereavement support. And during the treatment, maybe it's spending time with them and finding out their concerns, and if something can be done, that can be done. That's how we can give them the psychological support. So it's there is no shortcut. We have to spend time with the patient and family, find out their concern, and do whatever is possible.
Investigation also, sir. Actually, patient ECOG was 4, but still patient was not he was on bed, but he's not that unfit. And there was a documented weight loss of the patient. So whenever we did the malignant cytology test, it was always negative. See, we just wanted to see whether it's TB or something, or something we are missing, because his children also wanted to know that whether it's a cancer only, because we knew about it, that there's a progression of disease. The disease was aggressive from the starting only. Okay. So yeah, that was their wish, that we should do some investigation and we should find out, is there any other reason for his weight loss or something. So that's why we did this tab. And malignant cytology was always negative from the starting only. The malignant cytology was always negative. So ADA was 16. That why we sent for the CB-net and all. And we have done other investigations.
Okay.
Thank you, sir.
I mean, actually, that was a great presentation with all the details. Thank you.
Thank you, sir.
So we can wind up the session. So today, I hope we have a wonderful session. We have learned more things today, especially on opioids. While prescribing opioids, usually the doctors will be prescribing the drugs. The nurses or the pharmacist should give a proper instruction to the patient and the caregivers. This is very, very important. Because they don't know. Sometimes if the family members develop severe pain like abdominal pain or something like that, they will give same medications they usually. So you have to give a special instruction to the patient and the family. So these medications for your pain, other persons should not take. This is on important instructions. And the another thing is, these medications have only 3 to 4 hours action, so they need to take every 4 hourly, and it should take double dose at night. And side effect of morphine also. So sir was discussing all those things. So they should take Dalcolax, the stimulant laxatives at night to prevent constipation. And also they should take metoclopramide that is the life limiting things, but initial stage they should take metoclopramide 10 milligram TAD. So maybe after 3 days or 4 days they can discontinue the medication, that particular metoclopramide. And also you have to explain proper instruction about toxic effects also. If they develop toxic effects like delirium, myoclonus, or drowsiness, they should inform us. That the important thing you can give. And also you have to give the instruction about the breakthrough dosage also. They should take in between, they will develop a pain, so they should take the same dose as a breakthrough dose. So these are the important message you should give the patient and the caregivers while you giving morphine. Okay. Thank you, sir, for the wonderful session. Thank you, Meenakshi, for the excellent presentation. Thank you.
Thank you all once again. Thank you, Sunil Doctor. And I have shared the feedback link with you. Please kindly go through it. And